we're going to talk about a really important topic, which has been a very hot topic, not because it's a new thing that is happening in our bodies, but there's more conversation about it and more awareness, and it is important. Our goal is really to inform the community about what is happening in our body, and if you can leave this with just some reflection about yourself and what's going on. And we want you to be able to advocate for yourself with what you're experiencing with the providers that you see in the community and with the friends that you talk to and live with. And we're all here to support each other. So I believe the title is Thriving Through Perimenopause and Menopause, which we are all going to go through at some point if we haven't already. But I think first, before we can understand what that is, we need to understand why that is happening and what happens before perimenopause and menopause. So this is just going to be a quick review. But if we think about what is the reason for our ovaries and our uterus and the production of hormones, it is for reproduction. And we are born with the ovaries that we have, and every day we get older, the reserve that they have gets less and less. And so typically when we're in our early teens, our body starts to say, okay, it's time to start getting prepared for reproduction. And so our ovaries start to wake up, they start to produce several hormones, estrogen and progesterone being the two main types. And they start to work in a cyclic pattern. But if we think about when we first started our periods, if we go way back to when that was, there may have been a time where you didn't get a regular period. You didn't know when it was coming. You could be moody one day. The next day you weren't moody. Your boobs may be sore. You felt bloated, but it was pretty erratic and irregular. And then the more our body starts to do that and the more ovaries work, it starts to be a little bit more predictable. We like predictability. We're creatures of habit. We like to know what's coming and what to expect. And so when we have a normal menstrual cycle, we can say, okay, I just had my period, but maybe in a couple weeks, I'm going to start to notice my breasts are tender, I might get bloated, I might feel moody, and then either we get pregnant, and that's a whole other story, or we don't get pregnant and we get our period, and that cycle starts all over again. And that's a fairly predictable cycle for most of us. Not everybody, but for most of us. And so that happens usually in our teens and up till about our mid-30s. And then things start to get a little crazy because our ovaries are saying, you know what? Maybe I don't want to reproduce anymore. Maybe I don't have the capacity to do that anymore. And the hormones that our ovaries are producing, instead of being in a cyclic pattern, a predictable pattern, it's very unpredictable. So where we maybe used to know that a week before our period, we were going to start to have some symptoms. Now we may be having those symptoms when we're on our period or 2 days after we finish our period. And it's very unpredictable, very chaotic. So physically, there's a lot of changes going on, and then emotionally, a lot of changes going on as well. So those things start to happen around age 35. For some people, those things start to happen and can last many years, maybe 2 years, maybe 8 years, maybe 10 years, until we hit actual menopause. The definition of menopause is when you've gone one whole year without a period. So it's actually one day when you've gone 12 months without a period. And then everything after that is postmenopausal. So once you've gone that whole year without a period, your ovaries aren't really producing anything anymore. And so the symptoms that our body feels are going to be different. So we go from predictability to unpredictability to not having any periods. But when our periods stop, that doesn't mean that all the other symptoms that we're feeling are immediately going to stop. And when I was reflecting on the literature and when we talk about menopause and perimenopause, a lot of words that came up were highly complex, irregularly irregular, highly variable. So there's lots of terms. It's not a very black and white situation always because we're all different, and how our body experiences these changes is very different. You can have a room full of women that are all in the same phase of this, and I might feel fine. You might feel like a disaster. You may feel a little bit in the middle. So when we look, though, at what's happening hormonally in our body, we can pretty much tell what's going on, but how our body responds to those changes is really variable. So it's good to talk about it and to know what the possibilities of things that are happening, but also understand that everybody's journey is different, but that doesn't mean that it's abnormal. And so when we start to experience a lot of these changes, a common thing that we'll say is like, I don't feel like my normal self. Something is different. Something is changing. This can't be right. Just because it's different doesn't mean that it's abnormal. So I think we really want to empower you to know that change is inevitable in our body, and there's different ways to approach these changes. And we want, everybody wants to have good quality of life, and that looks different for everybody. Did you have anything to add?
Yeah, I think everything Anna said is great. And one thing with perimenopause, there's a lot of fluctuations in your hormones. So there's some of the hormones we'll talk about like decline more slowly and gradually, and some like estrogen is just really chaotic. So a lot of times I've heard perimenopause referred to as a zone of chaos. And I think that's a really great term, because when you're thinking about those symptoms too, it's variable woman to woman. It's also variable day to day. You might have a week where you feel great, and then all of a sudden you're like crying over a commercial and you're achy and you're having rashes that came out of nowhere. Like there's all these different things, and it's so variable. So just always knowing that, you know, what you're experiencing one week might change. And what you're experiencing now might be amazingly better in a year or two. Things change. Mm-hmm. Just like with adolescence, you know, we look at and we tend to have a little more grace for our adolescent and teenagers that are going through these hormone changes. And we know that it's going to calm down and normalize. And menopause and perimenopause is kind of a reverse adolescence. So we also need to give ourselves and each other grace that these things will calm down, but also that there are things that you can do to help.
Mm-hmm. Common symptoms, we're all probably experiencing to some degree a lot of them. So one, when you're still getting your periods, the irregular periods is very common, heavier bleeding, lighter bleeding, more frequent bleeding, hot flashes and night sweats, irritability, trouble sleeping, dry skin, thinning hair. So hormones affect our bodies in all different places. We have receptors for hormones all throughout our body. And when those hormone levels are changing, which is normal for them to do that, our body responds in different ways. And it can definitely be variable, and how long they last can be variable as well.
Things like joint pain. A lot of times we hear from women that have had frozen shoulder, and that can be a big sign. Brain fog, definitely. I hear from patients a lot of times that come in that are just, the biggest complaint I usually hear is, I just don't feel like myself. This kind of vague, nothing's just really hit you over the head, but it's like this vague, like, I just really don't feel like myself. But definitely that brain fog. Sometimes I hear from women, like, things at work are just a lot harder. Things I could do really easily are really hard right now. Brain fog, mood changes, some more irritable, kind of these more subtle changes that a lot of times when you look back, they've really been going on for years. And we've just tend, as women, just to kind of power through and keep going with all our responsibilities. And then when you finally start looking at it and talking about it and reflecting on it, you know, you realize, oh wow, there have been these like subtle shifts.
I think the other thing to keep in mind, which is important, is during this time where things are getting a little chaotic, inside of our body, our world around us is more chaotic as well. So for some, that is having children that they're shuffling around. They're having pets that they're taking to the vet. You may be having aging parents that you don't have control over what's going on with them. So in addition to the internal chaos that is happening, it's often a time where these external stressors as well. So we're not feeling well in our body, and we're trying to juggle all these things that are going on outside of us. And it's difficult to take good care of ourselves when we feel like we're taking care of everybody else. You know, you get on the airplane and they say, put your air mask on first. Easier said than done when you're trying to get to T-ball or you're trying to take your parent, to a doctor's office. So I think that really compounds all the things that are going on, and we just need to be mindful of that and be nice to ourselves, be nice to others, have limits for ourselves. Absolutely. The other thing that we hear oftentimes is, and when we look at the questionnaires, the two things that we think about a lot, weight gain and low libido. So again, we're not taking as much care of ourselves, so we may not be exercising how we used to. We may be getting food on the go more frequently. And so it's harder to put good things in our body when we're trying to take care of everybody else. Mm-hmm. And so it's not just hormonally what's going on, it's those external factors. For women, I've been doing this for 17 years. I talk to women all the time about their libido, their sex drive, their weight. I can probably name on like one hand the number of women during perimenopause and after that have a really great libido. So when we go back to thinking like what is normal and what is abnormal, the definition of normal is when you have a large group of people or things that are experiencing the same thing. So, but you can have someone who has been in a long-term relationship for 5 years, but they're in their 20s and their libido is not what it used to be. Mm-hmm. So we also, I think, have to remember that not everything is because of perimenopause or menopause. That time doesn't help, probably, but managing the physiologic symptoms of menopause is not always going to change everything that you're experiencing in life.
Yes, as Anna said, it's a normal part of life, but we want to look at what symptoms are bothersome and what's not bothersome. Again, everyone's experience is different. Also, everyone's values are different and what's impacting their quality of life. So if you took one on the way in, there's this handout on defining your menopause vision statement. I think it's really great, when you leave here, whenever you have free time or a quiet moment, reflect on what you want this period of life to look like and what you want the future to look like. Not everybody is going to have the same goals. When I have a patient come in, I will ask them, what are your goals? Are you thinking about, I want to be strong and active as I get older. I want to be able to lift my grandkids. I want to be that 80-year-old at the gym. Or are you worried about your weight? I still want to fit in my clothes. Or are you thinking about, I want to be able to travel, or I want to be able to expand my business or pursue my work. So my cognitive function is the most important. And everybody's is going to be completely different. And you want to get really clear on what your vision is and what your goals are. And that's going to shape how you look at everything else from a treatment perspective. And we're going to talk through all the foundations, the lifestyle medicine, the supplements, the medication options. But the first thing to do is just to get clear on what you want your future to look like, what you want this second half of your life to look like, so we can use that as a roadmap to guide all of those decisions. One of the things that got me really interested in menopause care was hearing from this Dr. Lisa Mosconi, who is a neurologist and researcher. And there's incredible changes that happen in your brain during perimenopause and menopause. So just like when we go through adolescence, their brains are changing. Everything's a little bit offline for a while, and then it prunes out things it doesn't need. In pregnancy, our brains change, and in menopause, our brains change. Our tolerance for some of the BS starts to decrease, and this is not a bad thing. This is great, especially if you get really clear on what you want in your life. You've probably spent the last few decades taking care of everyone else, being stretched thin, running around, like I said, running to sports, running aging parents around, working, all of the things, and might not have even had a moment to take a deep breath and get clear on what you actually want. And so sometimes menopause can be viewed, and in other cultures it's viewed as this time of this positive transition, that you're going through this experience that you can lean into clarity and vision and self-care and come out of it as a wiser, more clear version of yourself. So I want, hopefully, this isn't to take away from all of the crazy symptoms that go along with it, but hopefully you can leave here tonight also feeling more empowered that this can be a really positive time of life and can lead into an amazing second half of life. We know with researchers studying happiness that there's a U-curve of happiness. So we're kind of happy as a kid. The bottom of the U where we're least happy is midlife. And you think about all the things that women in their 40s and 50s are managing. It's pretty crazy. But then it starts to go back up, and part of that is because, again, those neurological changes, those changes in your hormones, you're not, your estrogen's not as high, you're not trying to raise a baby. Things change. You also just, like I said, get more clear. You might find you're a little more irritable, but sometimes that's the hormone changes. But I also encourage women to look at the irritability as a data point. What is it showing you? Is it showing you that someone's stepping all over your boundaries? Then that might be a sign, okay, I might need to make some changes. That's why I'm irritable. It's not always just you're being irritable. It's these are signs that something needs to change. And so definitely getting clear, on what you want your future to look like and what your values are going through menopause.
So when we think about what quality of life looks like for you, again, that's going to change depending on where you are in this process and what else is going on around you. So a common question, just to kind of recap, is where am I in this process? So when we think about the definitions of this, perimenopause can be 2 to 8 years leading up to your last menstrual period. And then menopause is that one day when it's been a whole year without a period, and everything after that is postmenopause. So really, that's that is the answer for where you are in this process. There's a lot of talk and a lot of options about testing. Do I need to get blood work to see where I am in this process? So if we think about, again, what's going on in our body during that chaotic perimenopausal time, your hormones are going to vary day to day. And so if we check them today, it's going to be one thing. If we check them tomorrow, it's going to be another thing. And also keep in mind, even if, let's say, we did check everybody's labs today and everybody had the same level, how you feel is going to be different than how you feel, and it's going to be different than how you feel. So, information is power, and that's definitely something that can be done, but it's not necessary to manage the symptoms or to provide recommendations for treatments that can give you good quality of life. So again, that's just it's a data point for where you are, but does not necessarily predict how you're going to feel today or how you're going to feel tomorrow or over the next 10 years.
And if you're going to opt for hormone therapy, your provider should be treating to your symptoms, not treating to your lab value, with the exception of testosterone, which we'll talk about later. But something to keep in mind. So while the lab value sometimes can give you a little extra information, or just sometimes women just like to see it, it's not what we're going to treat to. If you're having hot flashes, we're going to treat the hot flashes. We're not going to say, no, we need evidence first.
Yeah,
estrogen is down. We know your estrogen is down.
We can have evidence based on how old you are and what your menstrual cycles are doing. Mm-hmm. And then a common question, women will come in 5 years after their menstrual cycle, their last menstrual cycle, and say, where am I in this process? You've gone a whole year without a period. You are postmenopausal. Your body is not producing those hormones anymore. That doesn't mean that you're not going to have hot flashes or night sweats or have increased weight in our midsection or not desire to have sex. But we don't need to check your levels to see where you are, because we know where you are based on how long it's been since you had your last menstrual period.
Yeah, I think with hot flashes, that's coming from your brain. So that actually can go on until 65. So just something to keep in mind, because that's something I hear a lot too. I'm just going to tough it out because it should be over in a year or two. It might not be. It depends on the person. Just like when perimenopause starts, it's so variable too. It could be 35, it could be 45. So again, it's just so variable person to person. So you never want to just dismiss symptoms because of your age. If you're 35 and having major symptoms, talk to a provider. Don't just say, oh, I'm too young for this. Or if you're in your 60s and you're like, I shouldn't be having hot flashes, I'm just going to ignore it. I'm too old for this. You're not. It's just talk to your provider about this.
And it's about quality of life.
Absolutely.
Mm-hmm.
Yeah.
So if we think about, transitioning into what are the options to help feel better during this time, there's a variety, going from diet and exercise to changes in our lifestyle, medication. So Marielle, kind of start with that and we'll go from there.
Yeah, I'm going to start with the foundation, which is the lifestyle changes. This is foundational for everyone, every age, especially when I hear from women in their 30s. Now that it's become such a hot topic on social media, we hear a lot of women wanting to prepare, which is great. They're not going to be blindsided by it. So these are things that you can do at any age, just really building a strong foundation. So we'll go through those lifestyle components. So nutrition is one. That's super important. We want to be fueling our body for our life. So if you are, like Anna mentioned, weight gain can be common around menopause. If you start trying to live off of really minimal calories, you're not fueling yourself for your life. And actually, it can be counterproductive. I see this a lot, that women are used to kind of this fasting for a really long time or not eating until the afternoon. If you're not eating in the morning, they say within about an hour of waking up, your brain will actually tell your body to hold on to the fat stores and not burn calories. Men can keep burning calories in the morning and keep going and not have food, but for women, especially around perimenopause and postmenopause, you need some breakfast. So that's really important, a healthy breakfast to start your day. We see a lot on social media, a huge push right now for protein. Protein's important, definitely. We do not all need to eat like we are college football players. This is something I hear too. A woman come in saying, oh, I'm getting social media has told me to get 2 grams of protein per kilogram body weight. And they're like, but I'm gaining weight. But yes, if you're pushing for super high protein, and unless you're like training and you are, an elite athlete or out there doing like training competition, you don't need that much protein. The protein goals vary. So 0.8 grams per kilogram of ideal body weight as your baseline. So we do usually need more. And it's really about like 1.2 to 1.6, depending on your training level. So that's not a crazy amount. And typically we're going by more of like your lean body weight. So if somebody is really overweight and wanting to lose weight, I don't want them trying to hit 300 grams of protein a day because that's what their weight is. We want to look at more what's your lean muscle mass. So again, something that's more individualized, you can talk to a nutritionist about this, or talk to a provider, but also you don't have to go so overboard. We want our meals to be balanced. The lean protein, ideally from a plant source if you can, or at least some of your meals from plant source, so beans, lentils, tofu, edamame, tempeh. Those do show to reduce symptoms of hot flashes, so a more plant-forward diet can be really helpful with menopause. You want complex carbs. Don't be afraid of your carbs. We need those good carbs. Our brain runs on glucose. We need it. Sweet potatoes, brown rice, quinoa, beans, lentils, fruits, veggies. They're amazing for you. And healthy fats, avocado, nuts, seeds. So really, if you think about just kind of balancing your plate, having 3 meals a day, making sure you have a breakfast, trying not to eat too close to bed, all of those things. It doesn't have to get super complicated, but all of that is just going to give you good fuel for your day.
I just want to jump in real quick.
Yeah.
When we talk about what we're eating and the symptoms that we're experiencing, oftentimes women will have triggers that will increase their hot flashes, that will make us more irritable or have more difficulty sleeping. So really we're in a coffee shop, but and caffeine is great, but we do tend to be more hot and sweaty and can be more anxious if we're having caffeine. We definitely do not tolerate alcohol as well during this transition.
Absolutely.
Spicy food, garlicky foods, anything that can probably give you like heartburn or reflux if you've ever experienced that. It can also be a common trigger for hot flashes, night sweats, irritability, and poor sleep quality. It's very common. Life is stressful. Myself included, I want to relax. I'm going to have a glass of wine. I may fall asleep very quickly, but our quality of sleep is actually much poorer when we've had alcohol than compared to when we've not. And you're definitely going to be more likely to toss and turn because our internal thermostat is going to be dysregulated. So you're going to be hot and sweatier in the night if you've had alcohol, sugar, or caffeine, especially closer to bedtime.
Absolutely. And alcohol, like Anna said, is going to disrupt your sleep, which is actually going to throw everything off the next day. It's not just your sleep, but if you don't get enough sleep, your hunger hormones change. So the hormone that tells your brain you're full decreases, the one that says you're hungry increases. And when that's off and we don't get enough sleep, most people aren't going for a salad, a piece of fruit. They want something like chips or something heavier. So sleep is super important, and alcohol is a big disruptor. I hear this all the time from women in midlife too. It's just, they have a glass of wine or two and everything feels so much worse. The hot flashes, the anxiety, the poor sleep. So just being mindful, and thankfully there are so many non-alcoholic options now. There's a whole mocktail menu here. There's lots of different adaptogenic seltzers, so meaning that things that have herbs that are good to support your stress response. And sleep is so important. It makes it so much harder to deal with these symptoms too if you're not getting enough sleep. If you're not getting enough sleep, that alone is going to make you feel more irritable, more inflamed, because everything's going to feel a lot harder, and definitely harder to handle stress. And stress increases your cortisol, your stress hormone, which can also mess with your sex hormones. And so we really do want to be extra mindful of managing our stress in perimenopause and menopause, which, as Anna's mentioned, is a time where there's a lot going on in your life, so it can be really hard. But it's a sign just to really pour into that self-care, that stress management during this time of life. And that is also going to help change your symptoms. If you are super stressed out and not getting enough sleep and not taking care of yourself, it is usually going to make things like hot flashes and inflammation and irritability and weight gain worse, for sure.
And it's very easy to say these things. To do them is not as easy. So luckily there are lots of options to help manage. If you only have 5 minutes to sit and breathe or to go for a walk, that may not be enough to totally clear your head. And so when we talk about other ways to manage some of these symptoms, there's a wide range of alternative options, again, including using dietary changes to improve how you feel, exercise if you have the ability to do that. There's also really good research and data about acupuncture to help manage peri and postmenopausal symptoms, yoga, meditation. So I did this little breathing exercise at the beginning because it really does to help to center us and to tune in and just really reflect on what is important for us. And again, that reflection is going to be different for everybody. So there are a wide range of options if these lifestyle modifications are not helping or getting you that quality of life that you want. And so we'll kind of briefly go through everything. Again, we don't
jump back to the exercise. We skipped.
Okay, sorry, go ahead.
I'm just going to jump back 1 second to the lifestyle stuff as far as exercise goes, because we did see some of the questions. A lot of people are concerned about weight gain, especially around the abdomen. As your estrogen declines, we do tend to see more weight gain around the abdomen and actually in the triceps. So it changes where you store fat. So as far as the weight gain goes, we want to also focus on just these healthy habits and focus on distribution. So as far as, body composition. So if we're leaning into making healthy changes around menopause, and if you can start strengthening is amazing for you, especially during this period because bone loss is happening, and we know osteoporosis can be a byproduct of menopause. So we really want to lean into the strength exercises to start making sure we're protecting our bones. That's also going to help you with that body composition changes. So the more muscle you build, the more calories your body's going to burn. So it's really going to help a lot. We also want to make sure we have recovery time. Again, during menopause and perimenopause, with those changes in hormones, your body can feel more stressed. So really giving yourself that recovery. In your 20s and 30s, you might have been able to hit the gym 6 days a week and hit it hard and go to classes and be fine. If you're in your 40s, 50s, and beyond, you probably want to, do your exercise, and then the next day maybe just walk and do some yoga, and then exercise one day, and then have more some recovery days, or just more easier days where you're walking or just doing yoga. And again, helping managing that stress, and that's going to help too with some of that, the weight gain, the body changes around menopause. I also really always encourage women to, kind of step away from the scale a little bit. Maybe don't put so much value in the scale, because if you are making these great changes and you're eating healthy and you're getting healthier and you're exercising and you're building muscle, doing things that are going to help you for the long run, the scale might not change, or it might even go up, because we do know that muscle weighs more than fat. It takes up less space. So I generally encourage women, just lean into thinking about how do your clothes fit? How do you feel? That's way more important than just the number on the scale.
Yeah, it's rarely helpful at this point. And it's cruel when you come to the doctor's office.
I know, we have to.
Step one, is get on the scale, but that's just a data point. And so the important question is, what are we doing in our life to feel well, to feel stable, and to make sure that we are getting that quality of life and what's important.
Oh, and we'll go through supplements, and then we're going to finally get into the medicines, because I know a lot of people are interested in that too. But supplement-wise, again, everything is totally individualized, so please don't take anything I say as like a broad statement of that you need these supplements. But I do hear a lot of times questions about supplements around menopause and perimenopause, and they really can be helpful as part of that foundation of making sure your body is getting all the nutrition and nourishment that it needs so you can feel your best. Omega-3s can be really helpful for reducing inflammation and actually for mood also. Magnesium is a popular one I hear about all the time. That is great for stress and great for sleep. There again, you want to talk to your provider. Make sure you're getting the right dosage. I'm not going to make dosage recommendations because it's all individualized. B vitamins can be really helpful for mood and energy. A lot of times people are B12 deficient. It's a blood test you can get. If you're going to take higher doses, I would definitely get a blood test, or they're safer, lower doses. But even people who eat meat are often deficient in B12 because our soil is depleted now. So even the cows are deficient. So just a good thing to check if you're feeling tired and you feel like low energy, that's a big change. It's something you might want to look at. Vitamin D, super important for our bone health, for our immune health, for our mood. We get it from the sun, but we usually use sunscreen or inside all day. So sometimes we need to supplement that. Also, a lab test that you can have checked. We want to make sure that we're treating, to the right level, that you're taking the right amount of a supplement. We don't want you taking too much of something. Calcium, if you need it, ideally we do prefer you to get calcium through food. Things like tofu, edamame, dark leafy greens. There's lots of things that have calcium. And if you're not smoking or drinking too much alcohol, your body actually needs a little bit less. But trying to get it through food, supplement if you need to. Creatine's a hot topic we hear about a lot. A low dose of creatine for women can be great in supporting that strengthening. If you are not going to the gym and working out and strengthening, and you just start taking creatine, it's not going to make you stronger. You have to have the stimulus of the exercise. Same thing with the protein. If you're not exercising and lifting weights, the protein's not going to give you muscles. But with creatine, a low dose can be really helpful, and it can help with recovery. So if you feel like you're getting really sore, disproportionately sore from a workout, it might be a good thing to look into. Again, check with your provider, make sure that there's no reason you couldn't take it, any kidney impairment. And we're going to go, you want a low dose. So sometimes when I recommend creatine, women will look a little shocked, like, I don't want these huge muscles. Bodybuilders are taking it at a much higher dose. The data shows, for women around menopause, it's really helpful at a low dose. There's other supplements that we use, again, dependent on the patient. In perimenopause, sometimes they'll use something called Vitex berry. That can help your body produce more progesterone. It's not going to be the same thing as taking a progesterone prescription, but it can help in those earlier stages. We'll use black cohosh. Ashwagandha is one that I love for stress support. That can be really great, especially when you're trying to cut back or cut out alcohol. You can put some of these herbs in place to help you with stress. So ashwagandha is a great one. L-theanine can be a great one for that. There's passion flower. There's droppers. You can get like a seltzer and put a couple drops of L-theanine or passion flower in your seltzer and make that like a lovely calming mocktail that you could use that instead of alcohol. So those are the main ones. There's lots of supplements out there. Just be cautious always with supplements as far as what you're looking on social media. Because now that menopause has become such a hot topic, there are so many out there. And there are so many, people pushing the supplements. So you do want to be cautious, and you do want to make sure that what you're using is really going to help you, and you're not just spending all this money on something that isn't what you need. So we're going to go into the medications a bit.
And even though we're talking about all these options, of course, healthy eating, good activity, stress management, we all need that at all stages in our life. There are medication options to help some of these peri and postmenopause symptoms as well. That doesn't mean that you have to do these things. Absolutely. So you always have a choice. Again, Menopause is a natural process that happens in our body. And when we talk about managing symptoms, we are not talking about reversing the aging process. There is a whole market out there for that. And if that's your cup of tea, that's fine. But when we talk about management from a medication standpoint, this is really improving your quality of life. So if diet and exercise or supplements, you're not getting the relief that you're looking for to achieve the goals that you want, then we come into medication options. So if we think back to why am I having these symptoms, what's going on in our body, it is because our hormone levels are changing erratically, and then we're not producing them really at all. So the two main hormones that our ovaries produce are estrogen and progesterone. Again, you need to really talk to your provider if these are things that you're interested in, because there's a wide range of options, dosing, and routes to take these things. When we look at approval and studies for hormone replacement therapy, the main symptoms that they're FDA approved for are what we call vasomotor symptoms, that's hot flashes and night sweats, supporting bone health, but they do not have approval for weight loss, for libido, for feeling brain fog. Now, those can be some additional benefits of doing it, but when we're looking at what's the main reasons and the reasons that we have good data to prescribe these things, it's to help with vasomotor symptoms, can support your bones, and then again, there's these other benefits that you may get as well. So when we look at those two hormones, the estrogen and the progesterone, estrogen is the hormone that our body produces at a higher level in the first half of our menstrual cycle when we are getting a menstrual cycle. There are different formulations for estrogen. There are preparations that you can apply to your skin. There are creams or gels. There are little patches. It's like a little sticker that you place on your low abdomen typically. And there are oral estrogen replacement supplements as well. So we use what we call systemic estrogens. These are things that you would put on your skin or put in your mouth to help with these systemic symptoms that you may be having, hot flashes, night sweats being the biggest ones. It is recommended and considered safer to start with what we call a transdermal form first.
So the patch or a gel.
The patch or the gel. It tends to have less negative side effects or potential risks. We'll talk about those a little bit more in a minute. But some people do not tolerate that. They may have very sensitive skin or a patch doesn't stay on. And so if those things are not working, then we do have oral medications to use as well. If you have a uterus, whether you're getting your period or not, if you have a uterus and you are taking estrogen, you need progesterone as well. So again, going back to when we're getting our menstrual cycle, estrogen is the hormone that causes our uterine lining to get fluffy and engorged with blood to prepare for pregnancy. Progesterone is what combats that. And when you don't get pregnant, those levels drop and then you have your menstrual period. So if we are just giving estrogen to a uterus that's not responding to natural hormones anymore, that can cause a thickening of the lining of the uterus. That can cause funny cells to grow, and that increases the risk for endometrial cancer. So if you have a uterus and you are taking estrogen, you need a progesterone to decrease the risk of endometrial cancer. Did you want to say anything about that?
With the progesterone, so typically now we use micronized progesterone, which is a little pill, tiny little capsule you take at bedtime. It is your calming hormone. So we think about progesterone in pregnancy. You know, your body has a lot of progesterone at the beginning of pregnancy. It is an inhibitory hormone. It's a calming hormone because biologically, you don't want to be taking huge risks when you're newly pregnant. So this kind of calms you down. So what a lot of women find, it does really help with sleep and stress and anxiety. So even if you don't have a uterus and you don't have to have it, sometimes it's beneficial as well, just for quality of life. Again, it depends on the individual. With the progesterone pill, most women tolerate it well. Most women feel better on it. Some don't feel anything at all. Some don't feel good on it. Some have some mood changes. So another option is a progesterone-only IUD with your gynecologist if that's appropriate, but that can give you some progesterone as well for 5 years to protect you from that uterine hyperplasia.
And these things that we're talking about, again, they are well studied. They have FDA approval. You can get them with a prescription at the pharmacy. Oftentimes, if you're using insurance, there is, that will be covered under insurance, or you may have a copay. So these are things that are typically readily available, although I will say with this new kind of resurgence of awareness of perimenopause and menopause, a lot of manufacturers are having difficulty keeping up with production. So I have patients calling and saying, I can't get my patch, they can't get this dose, or we have to switch from once a week to twice a week. So be aware of that. And there are still some alternatives, but these, again, are all things that you can get using your insurance at the pharmacy.
And relatively inexpensive. So a 90-day supply of estrogen patches on average costs about $100, progesterone about $30. So depending on your insurance, of course, but just to be aware that these are FDA approved and you can use insurance and they're not overly expensive.
And they are bioidentically the same as what your body would be producing naturally if you were still getting your period. There are some women who they say, I'm not having hot flashes and night sweats, but my vagina is dry, or I'm getting frequent urinary tract infections. So when we talk about hormone replacement therapy, you don't have to take estrogen by mouth or by a patch if your symptoms are just related to your vaginal tissues or for urinary symptoms. There are vaginal preparations that are creams, tablets, or suppositories that you place inside the vagina. There's several different dosing options, but that just helps to locally estrogenize the vagina and support our immune system in our vagina and our bladder.
That can be incredibly helpful if you're having recurrent urinary tract infections. And it's also safe. So depending on, and we'll talk through non-hormonal options, but depending on your medical history, the systemic hormones might not be an option, but the vaginal hormones might be an option. So vaginal estrogen could be an option, especially if you're having vaginal atrophy or urinary symptoms.
There's a little analogy that I think can be helpful when we think about the changes in the vagina. Again, we have receptors for hormones all over our body, but when we think about the changes in the vaginal tissues, when our body is producing estrogen regularly, your vagina is almost like if you think about an accordion or like a paper lantern. So there's all these folds in it, and an accordion goes like this, and it can feel good, and it can be very happy. And then when our estrogen levels drop, those folds go away. The flexibility goes away. So you go from an accordion to kind of a paper lantern's a little bit crinkly. You can open it, it can go like this, but it doesn't want to do it very smoothly. And then you end up with a toilet paper tube. It's dry. It's not flexible. It does not want to move around. It does not want something bigger than itself going inside of it. So know that and this is aside from libido or the spontaneous desire to have sex. So while we have these life stressors going on that kind of put sex at the bottom of the list, or maybe not even at all on the list, we have these physical symptoms that are happening as well. Again, our body after menopause, you cannot reproduce anymore. Why would your vagina want to feel good, right? But we used to not live to menopause, much less past menopause. So our body has really not kind of caught up evolutionarily to how long that we're living. So, but there is modern medicine, and we're in a lot of times monogamous relationships. And so that may be an important part of a relationship is that intimacy. So we have to kind of attack it, if that's something that you want to do, from a couple different angles. Finding the mind space to want to have sex, and finding the vaginal help to make it more comfortable. And there are other non-hormonal ways to help the vaginal tissues as well. There's a slew of lubricants over the counter. I encourage straight up lubricant. You don't want anything that's like tasty or smells good or tingly or warm, because your vagina is not really happy anyway. So you don't want to irritate it even more. But a nice lubricant, coconut oil. There are some new products out there, something called hyaluronic acid, which you may be putting on your face to help with your facial tissues. So there are non-hormonal options to help the vagina feel better as well. But also know that it's not just the physical thing that's going to make sex comfortable. We need to work on how are we going to have more desire to do that. because our body remembers. If you have sex and it's painful, you're not going to want to do it again. And even if you think that you want to, there's muscle memory down there. So it tenses up. You may know if you've experienced some of this, when you go to the gynecologist and have a pelvic exam, it probably doesn't feel as good as it used to, right? Because we're going from looking inside an accordion to looking inside a very narrow toilet paper tube.
It's a great analogy.
Yeah, I like that analogy. But there are ways to help that. So if you're sexually active, you want to be, you're having these limitations, there are ways to improve how your vagina feels. But I always, encourage patients, reasonable expectations. We are not anti-aging with this, so nothing may feel like it did when you were in your 20s or even in your 30s, but we want you to have good quality of life, and these are things that can help improve that.
Absolutely. And we want to look at it from, step-by-step approach. So really those foundations, those lifestyle habits, if we needed supplements, oftentimes with hormones, we'll start with estrogen and progesterone if needed. And that alone sometimes can be enough to improve libido if libido is something that you're struggling with. And again, looking back at that vision and those values, I have plenty of patients that have low libido in their 50s or 60s or 70s, but they don't care. It's not impacting quality of life. Their relationship is fine. That's not a priority. I have other women that come in and it's really distressing. It's a big change all of a sudden, and it's really impacting their quality of life. So first off, I want to make sure that it's your quality of life that it's impacting. Mm-hmm. We're not trying to kind of get away from people pleasing. We want to make sure that it's actually impacting you. And if it is, there are options we can discuss. Again, restoring, some health to that vaginal tissue is so important because we don't really want to ramp up your libido, but still be having a lot of pain with intercourse. So making sure that all of the estrogen, progesterone, those are in place if needed. And then as far as from a libido perspective, we'll talk about non-hormonal options. We sometimes do use testosterone. So testosterone is tricky. In the United States, it's not FDA approved yet for women. In I think now like 8 other countries, it is approved. So I do expect that the United States will catch up on that. But so right now, there's not an FDA approved testosterone for women. What we can do is use men's testosterone, which is FDA approved. We just use a tenth of the dose, a tiny amount, depending on the patient. And with testosterone, we will check your labs first because I want to make sure, first off, we want to make sure that that's the problem. If if your testosterone, your free and total are totally normal and they're great, there might be something else going on. Taking testosterone, using testosterone is not going to fix relationship issues. It's not going to fix if you are just so high stress that you have no time to take care of yourself. We need to make sure that we're looking at it from a holistic perspective. But if you do decide to use testosterone, we do check your labs first to make sure we're giving you the right dose. A lot of times we hear about testosterone. Women sometimes are afraid to talk about it or ask about it because you think about men. I don't want to end up with facial hair or huge muscles or, receding hairline, all those things. We want to consider with the hormone therapy, we are just trying to get you back to a physiological level. So you are not going to end up looking like a man at the normal level. That's why it's important to check the labs and to dose appropriately. And that's why I do really like using the gel, because you can use a really small amount. We can recheck your labs in 2 months. We can see where you're at. We'll monitor it. So at that low level and getting you just back to a physiologic level that you want to be at, you're not going to be experiencing big side effects. Think about a teenager whose testosterone is kicking in. You may end up with some pimples, some oilier skin, increase in libido. Those are all kind of normal with testosterone. But again, you want to make sure that you're not being put on a really high dose. That's one thing I see sometimes with women coming in that have unwanted side effects because they've been on a really high dose. And so we do recommend if that's something that you're struggling with your libido and it's really bothersome, talk to one of us, talk to your provider, but make sure that your level's being checked, that you're just going on, the appropriate amount. So we want to be safe with that.
Yeah, and we're not, and that's not adding something back that you wouldn't be producing anyway. All women produce testosterone. It's just men produce much higher levels of testosterone.
Exactly.
And when we talk about, hormone therapy, there's all these benefits that we're talking about, which is great, which can improve quality of life. But there's some women that may not be appropriate candidates for it. Because, if you've ever gotten a prescription from the pharmacy, there's like a piece of paper that unfolds like 85 ways that tells you all the ways you're going to die if you take the medication. Those things don't happen often, but there are some women that have pre-existing conditions that we may say, you know what, hormone replacement therapy is going to increase your risk even higher. So you can see increased risk of stroke, heart attack, blood clots. So if someone has already had one of those things, they're already coming in with that risk of having it again. And if we give them some types of hormones, that's going to increase that risk even higher. Some women will say that, you know what, I can't worry about what's going to happen tomorrow. I feel so terrible right now. It might be worth some of those potential risks to feel better. Some women who have had breast cancer, there are some breast cancers that like hormones. So if someone's diagnosed with a breast cancer, they usually have testing to see if their type of cancer is receptive or grows more with certain hormone levels. So especially if someone has a breast cancer diagnosis, that is a conversation to have with their oncologist. What was their testing like? Are they a candidate for hormone replacement therapy or not? Going back to heart attack, stroke, blood clots, breast cancers, all these things, whether we're in menopause or not, are going to increase as we get older. We see these risks every year we get older. So when we study, for example, breast cancer in women that are taking hormone replacement therapy, there's like a baseline risk of anyone getting a breast cancer. And so when we add hormones, even at low doses, there is a potential risk that could be even higher. But the risk goes up every year we get older. So we don't, there's a lot of debate about what age can you start hormone replacement therapy, what age can you stop. We really have to look at what's going on right now, what are your baseline risk factors to determine is it worth adding an additional risk factor to that. If somebody is very low risk for breast cancer or blood clots and they're struggling, then hormone replacement therapy may very well be a good option for them. Again, it's a conversation, it's about quality of life, but there are definitely women who the risk might be too high to add something. And so there are other options that are non-hormonal to help with some of these symptoms. There are medications that target our thermostat. So when we think about the effects of hormones in our brain and our internal thermostat, it's very chaotic. So there are medications that target those thermoregulatory receptors in our brain to bring our temperature down. And those can work really, really well. So whether you are not a candidate for hormone replacement therapy or you're just freaked out and you don't want to do hormone replacement therapy, there are options that can help with hot flashes and night sweats. There are other medications that were traditionally labeled for anxiety and depression, but can also help with hot flashes and night sweats. We see those used oftentimes in breast cancer patients that can't take hormones, but they're having significant hot flashes and night sweats. They may take a medication that is labeled for anxiety and depression. It can also help with mood. A lot of times patients, they're not hot and sweaty, but they feel like an emotional wreck. And especially if you have pre-existing anxiety and depression, and then now your hormones are really chaotic, that can exacerbate that. So it may be, that would be an appropriate option, is to take something that improves those feel-good hormones in our brain, not the ones from our ovaries, but the ones that our brain make to help with some of those mood changes that we feel.
Absolutely.
Another, from a libido standpoint, there are two other options to help with what we call hypoactive sexual desire, which is actually a psychiatric diagnosis. So Marielle talked about testosterone a little bit. There are medications that you can take daily. Again, they increase those feel-good hormones in our brain, so we're in a better place to have sexual desire. That can be used for women up to age 65. And then for women who haven't actually hit menopause yet, there is an injection that you would actually inject the medication into your body with a little pin usually like an hour or so before you want to have sex. Again, that one increases those hormones in our brains that help us to feel good and increases blood flow to our genital area. Do you have anything to add about those?
No, I mean, those are the main ones that we use besides hormone therapy. Again, it's an individualized discussion to have with a provider who's knowledgeable about it. But I think one of the biggest things too, as far as the treatments we want to get across, is there are options for everyone. So even if you've had a history of breast cancer, there are other options. Nobody has to suffer through this in silence and without treatment options now.
And it's a large menu.
Yes.
And
it keeps getting bigger.
It keeps getting bigger. So when you are seeing your provider, I encourage you, if this is something that's really important, and to make an appointment, to have the time and the space to do that. We still support women coming in for their routine yearly checkups, for breast exams and pelvic exams. These are things that can be brought up at those visits. But it can be really helpful to set aside separate time to talk about these things specifically. There are so many things that we're trying to make sure we're screening for during like a routine wellness visit. So to tack on, obviously we're spending an hour or so, I don't even know what time it is. We're spending a lot of time talking about this. So if you have a maybe 20-minute wellness visit, that may not be enough time to really give you all the appropriate information, look over the risks and benefits, and find out what's the right option for you.
In the packets that you got at the front, the second thing after the vision statement packet is a symptom log. It goes through symptoms. It can be a great thing to keep track of your symptoms and bring that to your provider. It also goes through your risk factors and your medical history in relation to any of the treatment options. So if you do, if you're going to see your provider, try to fill that all out and bring that with you, because that gives them, a clear picture of, okay, what options might be safe, what might not be safe. It also helps you, because a lot of times you have all these ideas you want to talk to your provider about, and then you get in the room and you forget half of them, especially if you're in menopause. So it's a good idea, write them all down. As a provider, I love that if a patient comes in that prepared, because that really, we don't have tons of time. So that really helps us narrow down what can we talk about, what's going to be helpful for you. So I'm not just going through all the options that won't, that might not work for you.
Mm-hmm. And kind of going back to like what all the options are, there is new research that's emerging every day. I tell patients all the time,
absolutely,
this is what I know today, but that could change tomorrow. And I before this talk, I had gotten out my big medical book, and my 11-year-old was like, that's what you took around in your backpack? It was like this thick. So I referred back to the section about menopause and perimenopause. That information is always changing, but that information, when we look at what we were taught as medical providers in school, and even OBGYN physicians, the amount that was spent on menopause and perimenopause management was close to zero. And the main symptoms that were talked about were hot flashes and night sweats, absolutely, bone loss, and what we call vaginal atrophy. So because of social media, which there can be very good things about that, and this is going to be on social media probably, you may be learning about things at the same rate that medical providers are learning about them. So I just encourage you, if you come into your provider and you're like, I read about this, or I read about this, or I saw this, we may say, I'm not sure about that. I need to look into that. That's not because menopause and perimenopause are new things, but data is emerging and it's readily available at our fingertips all the time.
Yeah. There's also, there's the social media answer, there's the textbook answer, and then there's kind of the real life in the middle. Social media has been great to spread more awareness, and I think it's helping more women seek treatment. But also know that it's kind of, it's put out there as a one-size-fits-all, and there is nothing one-size-fits-all about menopause care. So, just know that one thing that you see on social media, it might not be appropriate for you, but you can definitely bring it up to your doctor, bring it up to your provider, have that conversation. Not every woman is going to want hormone therapy, but every woman deserves to have a conversation around what treatments are there for you and what's going to help you feel better and improve your quality of life.
And how long do I need to, if I'm doing a treatment, how long do I need to be on these things? Good question. We don't really know.
Yep. That might change.
It's different for everybody.
As data comes out.
So oftentimes it's going to be a trial and error. Okay, you've been on this for a while. Maybe you've kind of surpassed like the average age where we would see these symptoms. Let's try to come off and see how you feel. And I'm always surprised that oftentimes if you decrease your doses, patients say, you know what, I feel okay. Yeah. Or I forgot to pick up my prescription and I haven't taken it for a few days and I'm really okay. So going back to what's important and what your goals are for quality of life, you may not need it anymore. There used to be kind of like a pretty strict, like 5 years of hormone replacement therapy and then no more, but we know that these symptoms can last many years after that. Again, that doesn't mean that you have to take something if you're feeling okay. There's some women don't want to take anything. I'm going to put good food in my body. I'm going to put good energy out. And then on the other end of the spectrum, there is, give me everything you got. I want to feel how I did when I was 20. And there's a lot of in between. So knowing what's important for you, knowing that there are options, and good quality of life is really the goal.
Absolutely.